My name is Phillip Noel, and I am here for another episode of Maternal Matters, Voices from Virginia, a podcast series powered by the Virginia Community Healthcare Association. And today I'm here with two very special guests from Piedmont Access to Health Services, Marsha Mendenhall, the Chief Executive Officer, and Tammy Osborne, the Operations Manager for the OBGYN Department. Ladies, thank you for joining.
Thank you for inviting me.
I'd like to start with you, Marsha. I'd love for you to continue to introduce yourself as well as give us some more information about PATS,
Okay.
as well as the communities that you serve.
All right. As you said, I'm the CEO at PABS, and that's what we're known better than our long title. And we're on South Central Virginia on the North Carolina border. And we go from Mecklenburg County and Boynton in that area, Halifax County, South Boston, Danville, Pennsylvania County, Martinsville, and Henry County for maternal health.
And Tammy, we'd love to give you a chance to introduce yourself as well.
Thank you. My name is Tammy Osborne. I'm a registered nurse. I have 29 years of experience in maternal health and neonatal health has been my background. And I serve as the operations manager for the OB department at PATS.
And again, we're very happy to have you both. And so when we think about PAT's mission to provide care regardless of ability to pay, what does that look like in practice for pregnant and parenting families?
Well, as women come in for maternal health, prenatal care, postpartum, whatever, what we do is we get a household income for every family that is interested in our sliding fee. And there's a sliding fee that goes up to 200% of the poverty level. And there's like 5 different levels of what you would have to pay for each doctor visit. Also, if they fall under the 100% poverty level, we do have the ability to slide everything off if needed. But in particular, in our area, we have a outreach worker from the Department of Social Services, Pennsylvania County, that actually works with our mothers to qualify them for Medicaid while they're pregnant.
Yeah, amazing. And so your deliveries have grown significantly over the last few years. So in your mind, what is driving those increases?
Well, we started out in our Danville office with OB Care and then Chatham, which is Pennsylvania County. But in the years that followed, the hospital in Martinsville stopped delivering babies and OB Care department closed down. They had trouble recruiting to the area. And then in Halifax County, which is South Boston, the hospital there shut down the same thing. So we took over those areas and it caused that big increase. And plus, too, we've been there long enough that people know that we have quality OB care.
Okay. And then ultimately, how does that change just even the day-to-day for your staff there with that increase and the people that you're serving?
Well, we put prenatal care, GYN services in the 3 other offices, Chatham, South Boston, and Martinsville. We had it in Danville, but now we're providing it enough for those areas, which means you need more staff. You need more OB doctors. And so the cost of the service has gone up substantially for us.
So how have you seen that in your space as the operations manager with the OBGYN department?
We started in Danville and we've grown out to the other areas. So that poses a challenge when you have to provide staff and you have to provide providers there for prenatal care, postpartum care. So it can be challenging to have the availability and have access.
And to that point, the big component of this podcast series has been on that word access.
Yes.
And so when we hear about these maternal care deserts, right? How would you describe what that means with where you all live and where you work?
Well, the maternal desert really means you have an area or a region that does not have a delivering hospital or a birthing center, or maybe limited provider care in that area. And unfortunately, we are seeing that in some of our surrounding areas with the hospitals closing. And that's one reason why PATS extended out to the South Boston area, the Martinsville area, so we could be a bridge to at least provide some prenatal care and postpartum care. Even though they have to come to the Danville Hospital to deliver, we can offer that care in the off-site. So in those desert areas, PATS has been able to be an oasis, if you will, to provide those services for that region. So it's better to get a little bit of care, get your prenatal care, and then they'll have to drive to Danville for delivery.
Very important work
Very
that you're doing. And so with hospital maternity units closing and longer drives for care, what does that mean for someone who is pregnant and needs help quickly?
It can be very challenging, especially for first-time moms when you've never done this before, you don't know what you're expecting. So what we try to tell our patients that live in those areas that they have to drive in is, educate them on the signs of labor, things to look for, warning signs. If they present those signs, then pay attention and make your way to the hospital. Nobody knows when babies are coming, right? It could be a few minutes, it could be hours. So you really, it's a gamble. You don't know. So if a mom in those outlying areas finds herself in a situation where she feels the labor is, pretty strong, they can always go to the emergency room there and be assessed and to make sure that they're safe for the travel, and, be stabilized and then transported. Or they just maybe have to leave earlier when contractions are further apart. That way, when they get to Danville, then they can be there and deliver in a safe outcome.
And there's always cases where the mother may have a trauma, and they've got to get to the emergency room, and it's not delivery time or anything. So the hospitals are still mandated to do that emergency service.
Okay. And what are some of the drive times we're hearing?
Well, from Danville to South Boston, it's, roughly about 45 minutes, but that's, depends on where you are. If you're on the other side of the county, and then Martinsville the same way, it's about 45 minutes or so more. So you're looking at an hour's drive for some folks, or even longer,
Right.
to get to Danville to deliver.
I know we've kind of spoke about it a little bit earlier, but can you go in a little bit more detail about just the realities of the region that you serve? 'Cause it's a pretty big region.
It is. Halifax County is the second largest county in the state, and Pennsylvania County is the largest county.
Yeah.
So you're from Danville to the tip of Pennsylvania County is about 60 miles, maybe give or take a few miles, and Halifax is somewhat the same.
Wow. Yeah. And so you are working with a very limited number of obstetric providers in a large geographic area as well. So how does that reality affect access and planning for your patients?
Well, it affects the OB doctors. They've got to be on call 24/7.
Yep.
And so it stretches out their time to be in the hospital, but it also means limited time in our offices. So we carry 4 mid-levels that help with prenatal care and postpartum.
And PATS is one of the only options in the area, right? And so many of your patients are covered by Medicaid or have limited resources. What kind of role does that put PATS in for the region?
It increases the at-risk pregnancies, to say the truth of the matter. Tammy, I want to go in more detail.
It does. We have a large population of our patients do have high-risk complications with their pregnancy. So PAFS and one other OBGYN group is in our area in Danville. So if they can't get into the other group, they're going to come to us, and we turn no one away. We accept everybody. So it can be a challenge for us when we do see the patients with higher risk.
I'm seeing around 88% of pregnant patients have at least one risk factor.
Yes, at least one.
Has that just been increasing year after year? Like, give me a little bit more of the realities of that.
Unfortunately, yes, it has been. And they could range from obesity, preeclampsia, diabetes, and that's just if you have one, that's bad enough. But we see multiple risk factors. So they present very early in their pregnancy, they're already diabetic, or maybe they already have chronic hypertension, or maybe they're borderline obesity or already considered obesity with a BMI over 30. So when you're starting out your pregnancy and you already have complications, and then pregnancy some can add complications, then it just becomes a risk.
And delivery is very difficult also. Sometimes you've got to call in backup for some of the patients that's so critical and they need help. And we've seen those cases, and it takes a large toll on the OB doctors too.
Again, 88% have at least one. Do we have some with more than 3? That's 4? That is wild.
So if you have someone to come in and she's overweight and she's diabetic and she's got high blood pressure, that you're starting off with 3 doses. advanced maternal age, so she's greater than 35 years old. So it just adds another layer.
Mm-hmm. And a large share of the, you have named issues like substance use, diabetes, and a need for more education. How are those realities showing up in your patients' lives?
Well, sometimes, they show up and they come for their prenatal visit and maybe they don't know that they're diabetic. So we do sugar testing and we do diabetic testing. Sometimes they can just be diabetic while they're pregnant, gestational diabetes. Sometimes they come in, they're already diabetic. So what we're seeing is a big or maybe a lack of education when it comes to diabetes. They don't understand the foods to eat or what type diet to have or how important weight control is in that area and how to maintain your sugars, to monitor your sugars, to keep a sugar log and bring it with you to every visit. So we can then, if you need medication, we can prescribe the medication or help you have a session where we teach you diabetic education and teach you unfortunately, a lifestyle that you need to do while you have this. Sometimes after delivery, then, you can, it's just during the pregnancy, not delivery. But then if you're chronic diabetic, then that's going to stay with you.
Wow. So again, it's not just maternal health areas, it's very much general.
Correct. It is. But your general can affect your maternal. And the maternal can affect the germ. So it's all together. It's all linked together. And I think the more education we can provide, starting off with a healthy pregnancy, and you could get that good foundation, then we're more likely to have better outcomes, healthier babies, healthier mommies.
And I think that's one of the emphasis down the road that we need to be on is that we need to educate women, young girls, about how they need to prepare their bodies for pregnancy. And that's what's been lacking, it seems.
Well, absolutely. And how is preeclampsia and other serious pregnancy-related illnesses affecting the people you serve, especially once they leave the hospital and return home?
Right. Well, preeclampsia is a complication that complicates the pregnancy. It's most known as high blood pressure during pregnancy. Can also affect some of the organ systems. So it happens usually after 20 weeks gestation, you develop preeclampsia and you carry that with you. And we're concerned, of course, of high blood pressure, and then high blood pressure, if it's not treated, can lead to other complications. However, once the delivery takes place, you're not quite out of the woods yet because preeclampsia could then follow you into your postpartum time. So we need to let mom know that. Mom needs to really recognize the warning signs after delivery. So if she has headaches, if she has visual changes, any abdominal pain, things like that, we can tell mom, be on the lookout for these. If things start happening, please contact your provider because it does affect postpartum as well as the pregnancy.
And you have seen, and continuing with postpartum, you have seen high scores for postpartum depression.
Yes.
Right?
Yes.
And low follow-up for postpartum visits. What are some of the main reasons patients are sharing with you as to why maybe these follow-up appointments are being missed?
We do see postpartum depression in moms. Typically, a large number of moms will go through baby blues right after the baby comes, and that lasts a couple of weeks. But after that couple of weeks, if you're still feeling those sad times or anxious times, maybe increased hopeless feeling, when you have a baby, that's a lot on you, especially for first-time moms. As I mentioned, you've not done this before. It's all new to you. You have responsibility. You have a little one to take care for, and that can be a lot on her. So if we go past those 2 weeks and you still are feeling some of those, it's not fading, then that's the time that you need to seek help. So we do see moms on a 2-week visit for a postpartum visit, and at that time we do a depression screening. Sometimes we catch the depression at the pediatric visit. Maybe mom missed her 2 week, but she's going to bring the baby for their visit. So the pediatrician screens mom for her depression. And then they can alert us. And we're very fortunate at PAFS that we have our pediatric department in our building. So we have like a women's and children's building. And we've had cases where there's been a high score. So that provider reaches out to the OB provider in the same building, and then we can connect and take care of mom that way. Some of the challenges that mom has where we don't see the return visit on postpartum is maybe, transportation issues or childcare issues. There's also some moms think, okay, well, I've had the baby, I'm good. I don't need to go back. So we need to express it is so important to follow up with us through that postpartum period, that 2-week and that 6-week follow-up to make sure everything is okay and she's well on her journey.
Wow. It seems to probably be a big emphasis on internal communication then for multiple departments to communicate.
Yes, it is. Like Tammy said, it's really nice that we have pediatrics right beside the OB care in 3 of our offices. So it's that communication between the departments that really benefit the mother and child.
Absolutely. And speaking now to the system and the funding and sustainability, you have called your services a costly endeavor to do these services. And so what does it actually take to keep those services open year after year?
Pushing providers to see patients probably a lot, but it also, because we see 67% of our patient population in OB is Medicaid. It doesn't pay what private insurance pays. We do see some private insurance, but it's overwhelmingly Medicaid or uninsured. A little, no Medicare with the OB, I don't think. No, but it's hard. So we've always depended on a program that the federal government enacted many years ago called 340B. And that is a pharmaceutical program where we have 6 pharmacies because of it. That brings in extra income to the community health center for us to be able to see patients that are on the slide or difficulty making ends meet, because OB doctors are expensive.
Sure. Yeah. And to that point, recruitment has been a challenge.
It has.
Right. And so what is it like trying to bring and keep these providers in a rural, high need area such as this?
We work with a lot of headhunters to locate OB doctors that are just getting out of school, different residency schools, just putting the word out there. The HR director spends a lot of her time recruitment. And to get them to come to Danville or Southside Virginia in general, it's going to take a little bit more money than probably some of the other areas, because we don't have the other features that communities have, such as cultural arts. In the bigger cities, a lot of these OB providers have done their residencies in bigger cities, gotten used to that population. And we have to really sell the rural area that we live in. For some people, that's ideal.
For people who are not familiar, what is the 340B program and how does it help you sustain care for your patients?
A 340B was enacted by Congress many years ago to enable community health centers to have another funding source, because we are dealing with so many that are unable to pay the high cost of health care. So it's directly to the pharmaceutical companies where there are certain drugs that we can buy pennies on the dollar. And that enables us to still charge the full amount at the pharmacies for those drugs, and that extra revenue comes in to cover costs. Maternal health is one of the things that we are not mandated to do as a community health center. So it's difficult to get the revenue, but that comes from the 340B program for us. And right now there's a lot of changes being made in 340B, and that's coming directly from the pharmaceutical companies trying to press that issue. And that cost for OB, we're $2 million deficit for last year. So that was being covered by 340B, and with 340B going down, we'll have to really look at that program to see if we can continue it all.
And when you look at rising demand, financial strain, and workforce challenges, what keeps you committed to staying in this space, even with all those challenges being stated?
It's really the mission of what community health centers are, and that's so that health care is available to every citizen in the United States. And we alone serve 28,000 unduplicated patients. So as a nonprofit with a mission statement of providing health care regardless of the ability of people to pay, we don't want to end the OB program, because where would the Medicaid mothers come? That's how we actually got into it to start with, because the director of the Social Services Department in Pennsylvania County called us up and said, I have nowhere to send these Medicaid mothers who are pregnant. So that's how that whole ball got initiated at that time.
Wow. And I would love to hear it. When we hear about continued closures or things having to be shuttered, just even for a few seconds, if you had to shut down, what would be the realities again of that very big region that we have been speaking about?
Well, we'll continue with primary health care, pediatrics. We also have 5 dental programs throughout our region. These we will keep. It's going to be those other programs that aren't mandated by the federal government to have. And those are some of the support services, OB care, neurology. Some of those programs will probably have to be cut in order, because we've got to stay financially viable.
And what would that do to drive times and things like that?
Well, then you'd be looking at going to Roanoke from our area or to South Hill, Richmond.
It would be dramatic.
It would be.
For maternal health. PATS did not provide what they did.
It would be.
PATS is carrying the load of our community to provide the OBGYN services in our area.
And that's just seemingly for the delivery, but I'm thinking even those postpartum visits.
Oh, absolutely. Prenatal, delivery, and postpartum.
Yeah.
PATS is the umbrella to our region to support that. And if that goes away, our region would be devastated. These patients would not have care. You would have poor outcomes because patients would then show up to the hospital with no prenatal care. And we all know how important prenatal care is.
Right.
So to have PATS there to provide that is essential for our area.
And looking ahead, what would you most like to see change for pregnant and postpartum patients in Southern Virginia?
Continuity of service. That's to say, yep. And education.
Education. We definitely need to provide that education.
Where does education start?
In the beginning, even before we get pregnant. So maybe in school even. Maybe, childbirth classes. So once you find out that you are pregnant, that the early beginning, when you're excited and it's all new, we can introduce it then. We do it every prenatal visit. Every prenatal visit is an educational visit, whatever we're talking about, whatever trimester, whatever issue is in that trimester, we're teaching or educating them. So it's never too soon to start with education. But as Marsha mentioned earlier, I think it's the key is to start early and prepare yourself, prepare the body.
Okay. What do you wish that state and federal decision makers understood more clearly about what it takes for organizations like PATS to exist with maternal care?
The cost of it. First, the shortage of OB doctors. I think that needs to be addressed for sure. And really the importance of it for women to be healthy. And it's really a big education thing that needs to occur. And the money's got to be there in order for us to do it.
And of course, the importance of the 340B as well.
Yes,
right?
Absolutely.
Okay. And so for listeners who may never have to worry about distance or insurance or cost, what is one thing that you hope that they carry with them through your story and Pat's story?
I think that we're only healthy as a nation, as healthy as our workforce is going to be, and healthy as our kids are growing up and educated, that all these roles come together. It doesn't matter what economic status you are. It has all got to be together. And that the advocacy can come from women that don't need us for OB care because they're going somewhere else. It's just important that we all join together and say, hey, we want a healthy nation.
What about you?
Because it takes a team.
Yeah.
We can't do it by ourselves. It takes providers, nursing, support staff, ancillary staff, all the team to provide the care. And all of us as one voice to come together to support maternal health, because it's truly, we need help.
One thing too, it is such a high-risk profession to go into that we need to recognize that. And fortunately, with community health centers, we have what's called federal tort, and that's where malpractice insurance is paid for, and that lessens the cost for us. So that's a real benefit in our system. But that's why some people are choosing not to go into this field.
I got you. Yeah. And our final question, even with all the challenges, you are both still doing this work. And what gives you hope right now when you think about the maternal health in your region?
It's so needed. The hospitals have actually approached us about assisting us. So we're starting to have those meetings. That will hopefully help. They can fill in some of the gaps we're hoping. The federal government and Virginia Department of Health all have recognized the need for maternal health and the quality of it. So that's coming forth too. Community health workers are getting into this cycle, as well as doulas and more midwives. So all that plays together into providing services to everybody.
Yeah. And I think for me and so many of my colleagues, it is our passion for maternal health and those babies to give them a good start. So it's like we're looking into the future, right? So as the babies come forth, that's our next generation. So we have to invest in our next generation to keep us all healthy, to keep us going. So it's just a passion to take care of our mommies and our babies so we can continue to grow and thrive.
Well, absolutely. And we'd like to thank the both of you again for coming. And thank you to the viewers here again with the Maternal Matters Voices from Virginia podcast, powered by the Virginia Community Healthcare Association. We would like to again thank our guests, and we look forward to seeing you again soon. Thank you.